Dear colleagues, it is a great pleasure to welcome you to CPPS Tricks World Patient Safety Day 2022 that will be held from 21 to 23 September 2022. In CPPS Tricks, through these events, we need to build a community understanding and awarenesses to make safety in general is the primary goal for all healthcare stakeholders, either administration, leaders, physicians, nurse, pharmacists, or others healthcare provider. Together with the partner of the family and patient and all community safety advocates. CPPS Tricks Patient Safety Day will be a 3-day comprehensive free activity, which are designed to be a one-of-a-kind knowledge sharing event and a real opportunity to learn and network, where you will hear 2 5 live session or lecture. Inshallah, the aim of this session is to raising awareness for the need to adopt a systematic approach to improve medication safety and promote safe medication practices in our facility, to prevent medication error and to reduce medication-related harm, where medication-related harm accounts for up to half of the overall preventable harm in medical care. We need to build awareness or a culture of medication without harm. No matter who are, take action and save life, where zero harm is the only acceptable goal in our practice. We need to be a safety advocate, so united for medication safety must be our pledge. Today, we start the first session in this valuable event with one of our experts, Dr. Fuad Sadek. Dr. Fuad Sadek is a medical education and research trainer in King Fahd Hospital of Imam Abdurrahman bin Faisal University in Dammam, together with his main specialty as a plastic surgery consultant. Welcome, Dr. Fuad, and thanks for your commitment to participate in this event and share your knowledge and experience with us. Today, we will hear a lecture under a title, Toward a Safe Medication Prescriptions. Welcome, Dr. Fuad. Tfaddal. Dr. Fuad. الصوت بس يا دكتور فؤاد، ممكن تفتح المايك معلش.
The voice is okay.
Okay.
Okay. Welcome everybody. Happy National Day to all our Saudi colleagues. Inshallah, I will not make it very long because we are supposed to be on vacation and enjoying somewhere else, but hopefully it will be of benefit to you. Today, we are going to talk about safe medication prescription. This means avoidance of medication errors. Let's start by definition. What is a medication error? It's any preventable event that may cause or lead to an inappropriate medication use or to a patient harm. What is most important here is preventable. You cannot remediate or seek a solution for something that is not preventable. Where does medication error occur? It's a journey from the idea starting in the mind of the physician that we need a medication. He will prescribe it. Then after prescription, it will go in the system, either in the electronic system or by hand in some places, but I think most of our hospitals have an electronic system. Then to the pharmacist will provide the drug. If the patient is an inpatient, Then a nurse will be in charge of dispensing the medicine and giving it to the patient. Then finally, the medication will be inside the patient. This is the evolution of the trip of a medication. So, as we said, the attending physician will evaluate the patient. He will establish the need. I need that drug. He has to select the right medicine, okay, and prescribe the medicine. What are the items involved in this prescription? The exact name of the drug, the route, the dose, frequency, and the duration. He will enter this information in the system. This is what we call transcribing or documentation. Then it will go to the pharmacy for dispensing. Up till now, it is something virtual. It is words in the computer. Once we go to the pharmacy, now it is the real thing. The drug is there, and somebody is going to pick up this drug and give it to the patient. So the role of the pharmacist and clinical pharmacist are very important. What they will do, they will review the order. They will confirm the transcription. If they think something is weird or something has a discrepancy, they can contact the prescribing physician. Then they will prepare the medication, write all the instructions on it, and then dispense the medicine. After that, if the patient is in-house, the nurse will review the prescription, confirm it, review any warnings or interaction or allergies, evaluate the patient that the patient is okay, he can take his medication, then starting administration of the medicine. She will not start the administration and leave the patient away. She has to wait for some time to see if there is any response, any allergies, or any adverse effect. So in the hospital, the 5 rights: right patient name, right medication name. Usually it is preferable to be a generic name. Right dose, right time to be taken, morning, evening, or if it doesn't differ, and the right route, per os or subcutaneous or IV or whatever the case. What can go wrong through this journey? During the prescription, the name of the drug may be wrong, the dose may be wrong, there could be allergy. And with the electronic system, we have something that is useful for prescribing doctors. Once you open the system and you open prescription, the system will not allow you to prescribe any medication unless there are the listed medication allergies of the patient inside the system already. If not, you have to enter them. If not, it will not allow you to prescribe any medication. So this is something good in favor of the electronic system. You will transcribe everything, okay? And then the pharmacist will dispense it, and then the nurse usually will administer the drug. Here, most of the information about the drug, the system, as I told, will not allow you to make so much mistake. But at the bedside with the patient, the nurse has a very important role, because she may be the lucky one who will describe the first allergy to this drug with the patient. So she should be aware what are the presentations of this allergy and how to act in a correct way to save this patient and prevent harm. The electronic information systems are, I think, widespread now. What is the idea? The idea is that in a safety culture, what they discovered that most of the errors occur during communication and handovers. You have some information about the patient, you are handling the patient to somebody else, he does not have this piece of information. But if we have an electronic file, anybody can access the file, he will open, all the informations will be there. It will be easy, just the click on a computer, no need for personal communication. Usually in the file, you will find the history, the allergies, very important, immunizations, the diagnoses, and this could be multiple. The patient could have more than one pathology with more than one category of drugs he's taking together, treatments, what he is already on, and if you wish to update it, the lab and test results, radiology, and previous medications. So the point is that to have all this in one file. This file will have many profiles, many applications. One is for the physicians, another is for the nurses, other is for the voice is okay? Hello?
Yes, doctor. Yes, doctor. Voice good.
I keep getting messages.
It's clear, doctor.
Clear.
Let's continue. It's okay, I will continue.
Okay, doctor.
So other physicians, if there are 3 or 4 physicians handling the same patients, they will know the whole profile of the patient. What are the medications he's on? If they want to add something, is there any interaction, any harm, any disability in the patient that will prevent it? And for the nurses, they will have their own version of this electronic file. Now, also the patient has his electronic file on the mobile. In many hospitals, he has his file on his mobile and his appointments, and he can book an appointment, ask his physician for an investigation. And most important in the West is insurance. What is covered, what is not covered. So this makes the life of everybody easy. And this is just to give you an idea, the patient number, his name, date of birth, gender, the folders with the diagnostic results, the previous prescriptions, the physician notes, all in one place. And also, we wouldn't forget to mention how to contact him, because this may be an outpatient. And if there is a mistake as a last safety net, you will call the patient and tell him, there is some issue with your medication, please come and visit us back. Here is a very important concept in safety. This is called the Swiss cheese model. If it is new to some of us, Swiss cheese is famous that it has gas bubbles inside it. And these gas bubbles will make holes. If you slice it, you will find holes. Supposingly, the holes will not be aligned in the same direction. So if we put the slices apart, one hole will not be superimposed on another. What is the idea regarding the safety? Is that I will make as many checkpoints as I can, so that if there is a human error in some step, it will not bypass the second step. It will be stopped. Then a third one, then a fourth one, then a fifth one, because if they pass through all the holes, it will lead at the end to a patient harm. This Swiss cheese model, this is what occurs in the mind of prescribing physician. He has in mind 4 or 5 drugs, but there are factors in the patient, his age, his weight, his kidneys functioning, his liver is not functioning. Are there drug interactions? Only the drug that will pass through all these cheese model holes will be prescribed to the patient, and it is claimed to be safe. Also, there is a rule in safety and in quality improvement. To improve something, you have to measure it. And to measure it, you have to have a data. Data about medical errors are only available through reporting. So in the culture of the institution, it should be that report any adverse drug reaction. You will not be punished. It will not have any sequences on you, but we need this data to improve the safety of this same drug. Don't assume that the drug, once outside the manufacturer company, they know everything about it. No, some very important side effects will be discovered after selling the drug, after it is in the market, and it is the responsibility of the hospitals to give this feedback to the company. So in medication error reporting, what is the purpose? What is the benefit? We get information about the medication error in our institution. We have a database. What are the patterns? We analyze, we know where are the defects so as to minimize the recurrence of these same errors. What would be the causes for prescription error? It could be the medication itself, could be the staff, could be the working environment, could be the technology as we are using an electronic system. Regarding the medication, some medications, they look alike. If they are put in near each other in one shelf, you can take one for the other. The package could be similar. If you are giving a phone order, the name of the drug could sound alike. This is why we are advising that if you give a telephone order, please repeat the order at least twice before you hang on. Some people are raising hand. If it is for a question, please collect all the questions at the end. You are welcome. We will answer everything, but we need to get on with the presentation. Staff factors, distraction, especially if they are under workload. If there is no professional development, they don't have the knowledge, they don't have the experience. Task and technology, also related to professional development and related to the electronic system you are using. If the patient information or record is unavailable, inaccurate, some false information, incorrect computer entry, illegible prescription, this is very important. Some people, they don't want to wait for the clinic. They will go to another doctor. Please give me a refill, prescribe this medication for me. And this is totally wrong. You could make an error very easily. Another thing, don't give a prescription over the phone. Somebody is calling you and then he's telling you, I have so and so. You make the diagnosis over the phone. You don't see the patient and then you put the prescription. This should not be allowed. Heavy workload, especially with our colleagues, the nurses. If you are giving her 2 nurses, you are giving 8 patients. And she has lots of writing, lots of medication to give, lots of complaints from the patient. For the heavy workload, we are humans. She is prone to err, especially the peak hour. This peak hour is when you are handling to a next shift. You need to finish everything and you are dreaming about leaving the hospital, going home. So this will increase the errors. Environment and work, this is mainly in the pharmacy. Are you storing the drug in correct way as recommended by the manufacturer? Are you labeling it right? Are you giving the instructions right? Is the container the one the staff are familiar with, or sometimes it is changed, they don't recognize it. In the prescription writing, I will give you some examples of prescription error. Milligram and microgram could be missed together. BD and BID, bedtime and twice per day. CC and milliliter, nobody knows CC. Everybody, I think, knows milliliter. Eye and ear drops could be confused. Intravenous, intrathecal, and so on. So how to prevent the errors? First, try as much as possible to use the generic name, pharmacological name, not the company name. So you could write glipinlamide instead of Doanil. Don't use abbreviations. If abbreviations, we have international abbreviations everybody familiar with, but if this is not an international one, don't use it. Like metformin, you are writing MTF. What is MTF? Nobody knows. Also use clear instructions. Gute means drops in Latin. Who is studying Latin? Write drops, make it easy for yourself and for the others. If you have a decimal, put the 0. It will not take too much effort. 0.5, don't put point and 5. Point can be missed. If there is something after the decimal, put a 0. Verbal orders, use verbal orders as minimal as possible, because over the phone, not all of us have the same accent, and if you are lucky, something will go wrong in the place of another drug. And identify the drug allergies, especially if you are, as I said, the lucky one who will discover it. So drugs that are prone to errors are the look alike or sound alike. Similar in physical appearance, similar package, the package is the same, or the name spelling is near to each other. See, all the 3 ampoules are brown, all of them containing 1 milliliter. One contains vitamin K, the other contains neostigmine. This is something, this is another thing. The other has vitamin K also, 10 milligram. So here the dose is totally different. This is why you will see here that they are putting the 10 with the red label, just to catch your attention. Sound alike, as I said, in phone orders, like clotrimazole, cotrimoxole, dopamine, dopitamine, they sound alike. So better to repeat it at least 2 or 3 times to get sure. So double check the drug before dispensing, before administration. Contact the prescriber for the pharmacist if something looks funny, something looks not all right. Do not assume everything is okay. We receive these calls all the time in the clinic. They are welcome, no problem. You will know where the trouble is this time, the looking alike and sounding alike medication. Inside the pharmacy, use tall man lettering. What is tall man? Simply use uppercase for the section of the name where you are suspecting that this will cause trouble. And if it is a very dangerous drug, put a label that be careful about it. Here, medications that look alike, don't put in the same shelf. If in the same shelf, put one at the start, one at the end. Put extra label, put the red label. As we will come after that, for the high alert medications, we are usually putting red labels. This is the tall man lettering. Tall man lettering means part of the name we will put in uppercase letter. And this is an example on the shelf. Here, these brochures you will distribute or put on the wall in the pharmacy or in the ward to give warning. Be extra careful, we are not the same in any similar drugs. Here, it is not the name of the drug. Here you want to give a clear instruction. For the fentanyl patch, we want to cut it diagonally. Why? To make the patch cut equally in half. If we cut it in another direction, maybe one part will be small, one part will be bigger, so the dose will be different. There are always guides for handling the look-alike, the sound-alike medications. High alert medications are the ones with narrow safety margin. What do I mean by safety margin? Means the distance between a therapeutic useful dose and the toxic dose is small. Means you don't have a very big safety margin. So we take care of these drugs because they may be sometimes fatal. This is the extra cautionary label. You see this red labels here. And you can have a guide for high alert medications. So what if it happens already? خلاص, there is a medication error and it happened. Don't try to concentrate who has done it. We are trying to improve the system. So we are searching why did it happen to prevent it from occurring again. Remove the error by removing the why, not punishing the staff. Now there is raised awareness about second victims. Means that the staff will make an error, he will get sadness, he will get depression. He did not commit it on purpose. In fact, he is also a victim, a second victim after the patient. So we are concentrating on the system, not on the persons. Once it has happened, we have to collect our data and try to make statistics and inferences about the causes. Usually it is wrong patient information, wrong dark information, communication. Communication, this is very important, especially when handling patient from one section of the hospital to the other. Some causes in the pharmacy, the labeling, the packaging, the storage, if it is not the required storage by manufacturer, we are giving a bad drug for the patient. Staff competency and education, patient education, patient should be involved and patient is important. So, what is the role of the attending physician and the resident? Write the drug orders on time, because if you don't write it on time, you will forget, you will go home, you will call, you will give a phone order. Write the generic name to avoid confusion. Read back, if you are taking the order from a consultant, read back, did I get it right? You mean which drug, in which concentration, BID, and so on. So for the nurse, try to order the drug with the generic name, read back, insist on confirmation, always double check. Before administration, this is the right drug and this is the right patient. Give the drug on time, because you may be busy somewhere else. Even when you come back, you will forget something, you are apt to make a mistake. And don't be afraid to report any adverse drug event. We need it. It's useful information. So to sum up, write the generic name, write the dose, the frequency. If you can add the indication also, put your signature or printed name, your stamp, the time and date, and use as little abbreviations as possible. If you have to give a phone order, try to read it back many times, or try to avoid it from the start in the morning round. Everybody should be in the morning round. Everybody should read what are the medications. If you are planning any change, the best time is during the morning round, so that we will predict what will happen and we will have no surprises. What is a medication reconciliation? Medication reconciliation means that if you are handling the patient from one setting to another, from one apartment to another, from one doctor to another, we have to go back through all the medications. Some of them will be stopped. Some of them will be rewritten. Some of them will be new. Is there any interaction? All this, we have to correct it in one final form so that we will avoid duplications, emissions, double dosing, and events like that. AP here refers to the attending physician. Attending physician is the physician primarily in charge of the patient, but we can have other doctors as consultation. They will suggest medication, but it's always the duty of the attending physician to make this reconciliation, and he will be responsible that everything with the patient will be going in the right way. This is his primary responsibility. I will take 1 minute. Malish, I have a phone call from the hospital. 1 minute and I will be back. كده اوكي؟ كده اوكي؟
اوكي كده.
طيب يبقى هنقول من الأول how medical reconciliation is done. We will use the drug database. It could be electronic or it could be paper. يعني some of our nurses know that we have something called the Cardex where all the medications were written. Then the attending physician, the primary treating physician, is the one responsible for the patient. Means that all medications he will write, it will be mandatory. The nurse will carry the order. Medication from other doctors, consultation doctors, the ones that are not the primary attending physician, he will have to match them with his medications. Maybe he will take them, maybe he will refuse, maybe he will discuss with his colleague and readjust it, but he is the one responsible, okay? Some will be continued, some will be stopped. Sometimes we get angry with our nurses. She will tell you, you have to write everything again. Okay, this is safer. It will take time and شوية effort, but it's okay. And then we will have to communicate the new list to all the doctors treating the patient, the nurses, and to the patient himself. Some patients are cooperative and they are educated. And if you ask them what medication he's taking, he knows everything. He's very informative for you. As I told you, you do it on admission to revise the drugs he was taking at home after surgical or high risk diagnostic procedure like endoscopy or so on. If his condition improved from ICU, he went outside. If nothing happened for him, he has a very smooth hospital course every 7th day. You have to check, don't leave it. These 7 days will go down to 3 days if you have more doctors coming and prescribing. After change of the attending physician, maybe he went on vacation or something, he delegated his patients to somebody else, or the resident if he shifted to another place. After resuscitation, critical condition, before discharge from the hospital, because probably will dispense other medications that he will take at home. Here, see that the antihypertensive drugs was changed when he was inside the hospital. Oral hypoglycemic, usually we are changing it to insulin. And when he goes back home, back to his oral hypoglycemic. As I told, we know the breakdowns of the safety when we get information from the staff in the field, from the front line. Most of them are coming from communication, handling over. You are giving less information than your colleagues needs to manage the patient. High-risk medication, as I told before, they have potent cardiovascular or neurologic effects, means that sometimes they can kill. And they have narrow safety margin. You don't have much space in the dose and you don't have much time to manage the patient. So we call them high risk or high alert medication. Usually they are labeled in red, and usually not everybody in the hospital has access to them. Ideally, all staff should know about them, but people in the OR and in the high dependency unit, they should know them because they would use them more than people in the ordinary ward. Like, for example, insulin. Insulin, we should remember that hypoglycemia kills. Hyperglycemia, no. So hypoglycemia is very dangerous. So when you are giving insulin, especially when you are giving it by pump or IV, this is a very high alert medication. Second, the electrolytes acting on the heart, the potassium, the magnesium, the calcium. Sodium bicarb. If you give excess sodium bicarb, treatment of acidosis is amenable. Treatment of alkalosis is very difficult. You will be into deep trouble. Dopamine, dobutamine, they act immediately on the heart. Lidocaine also can suppress the heart. Heparin and coumadin, they act on blood coagulation, and one is antagonizing the other. So if you are in a position and you are required to write a high-risk drug, write it completely. Don't write it too frequently, only when it is needed. Like, for example, if you have a potassium deficit, if the patient can take it oral, it's better than giving IV. The danger is much less. Reconcile with other drugs, have it checked by the head nurse, have the clinical pharmacist review the drug order. Now, clinical pharmacists are very helpful. Don't be shy and hesitate to contact them. They will help you. Monitor the patient status after every administration, and also during the administration if it is an IV drip. What are adverse drug events that we are seeking to record? It is an unexpected, unintended, undesired, we don't want it. Unexpected, we could not prevent it. It's either excessive response of the drug or an undesired response of the drug. That will necessitate that we stop the drug or change the dose. The dose was not written correctly. Or if the patient is in the outpatient, he had to be admitted. Or if he is inpatient, he suffered more morbidity, he had to stay longer in the hospital. We had to support the supportive treatment. Like, for example, he started to develop apnea or got unconscious and we needed intubation. Lastly, and hopefully it will not happen, it will lead to disability or a permanent harm or death. When we are spreading a culture of safety, we should remove some myths, some wrong ideas. That once the drug in the market, they know everything about it. No, it's wrong. When the patient has some adverse drug reaction, we could not stick it to the offending drug. No, this is not right. You have to be 100% sure, or otherwise don't report. No, we know that we could not be sure 100%. What the hell is one case? It will not make a difference. No, one case plus one case plus one case. This is our database. Some other factors than the drug itself inside the patient would affect the effect of the drug, and we have to put it in consideration. Mainly liver disease, because liver, this is the factory where all the drugs are metabolized into either inactive metabolites or sometimes more active metabolites. Renal disease, because the kidney is where some of the drugs are excreted in urine. So if you have renal disease, you should adjust the dose and don't give drugs that can harm the kidney. Cardiac disease and myocardial infarction, they reduce the blood flow. Viral infection, hypo and hyperthyroidism, they also affect the metabolism of the drugs. Drug food, this means inside the GIT. Like, for example, tetracycline and milk products. If you milk them, the milk will change the tetracycline, it will not be effective. Warfarin and vitamin K, they are antagonists. Grapefruit, because it has too much acid in it, it will affect the drug and the absorption and the effect and everything. Before administering the drug, drugs like phenytoin, even if you want to give them as a drip, You don't give them in dextrose because it will precipitate. Amphotericin, it's with saline, it will precipitate. Gentamicin and beta-lactam, no, don't give in the same bottle. Absorption in the GIT also could be affected, like for example with the proton pump, they increase the pH, absorption will be reduced, or like cholestyramine who binds with thyroxine and other drugs. As we said, it could lead to inactive metabolites or active metabolites, increasing the effect and sometimes leading to a toxic effect, the metabolism of the drug. It will give you a new substance that will have a different effect. Okay, if it happens with a physician or with a nurse in the ward, what should we do? Stop the medication, stop the harm, report, write a reporting form, call the clinical pharmacist and ask for help. Don't hide it. What will happen? There will be a therapeutic committee, and this therapeutic committee will process the problem of the drug, and then they will determine if it is a problem in the drug or problem with the staff. But nobody should be punished. Now you will relax a little bit. These are 8 questions. The answers are there, but just to test yourself if you have got the points we are discussing. So we will give you 5 minutes to take these 8 questions, please. Each slide, I will give you 2 to 3 minutes. Write the answer if you can in a paper and see how much you got right from the first time. Okay, we will shift. Okay, next. Okay. Now you can score yourself. If you have 6 to 8, this means you are a safe prescriber. Now, one of the most important stakeholders in medication prescription safety is the patient himself. Let the patient be aware what he is dealing with, because he is the target of all this prescription and all this management. For the patient, where can medication incidents or errors occur? In the doctor's office, prescribing some wrong drug or wrong dose. In the pharmacy, he could be given a wrong drug. Or sometimes there are over-the-counter drugs or herbal drugs. He could take them and they will lead to interaction with his medication. At home, when he is taking or using the medication, you see, when you grow up, at the age of 40, you have one bag of medication, regular medications. You will take everywhere. When you are 50 and then when you are 60, it will increase and increase by time. Yani God give you a very long life, but your medications will increase. So try to make a list and try to record what medications you are taking, how much per day, and for how long. Because it's very easy to forget. Some companies are kind. For example, if you have an antihypertensive, they will write over the tablet Monday, Tuesday, Thursday, because if you have taken it, khalas. Sometimes when you are not concentrating, you could take 2 doses in one day or omit 1 dose. You are not sure. So better to keep a list. If he is inpatient, dispensing the medication from the pharmacy, there could be an error or a mistake, or at the bedside, not giving the patient the right medication for him, giving the medication for another patient, or in a wrong dose. So why we seek the help of the patients? Patients are the best source of information. You are handling 100 patients. He is handling himself, only one patient. So he knows more about himself. And always give them the impression that they can ask questions as much as they can until they know the right medication, the right dose, whatever they want to know about the drug. For him, for the patient, he should list what he is actually taking, how he is taking it, what is the route, what is the dose, and why. It is antihypertensive, it is anti-diabetic, it is for the blood coagulation, whatever, in a simple form. Writing the name of the medication, what is the strength of the tablet, how many tablets he will take, and how frequent. He should also know what is used regularly, like the antihypertensive. You cannot take it one day and omit it the second day. The over-the-counter medications, the herbal medications. Some herbal medications are really harmful and they are dispensed without prescriptions. The doses, the strengths, and how and when to take his medication. It's good for him so as not to make mistakes. His doctors, if he is admitted, the nurses, the pharmacists, we want to know the right information. And in case of emergency, if, for example, he's unconscious, he's brought to the hospital and he has his own list, you will know what is the likely problem with him. So always for the patient, ask as much as you wish. What is your health problem? What drug do I take and why do I take them? At hospital discharge, especially at hospital discharge, spend some time with the patient. He will be probably by himself. He could be coming to the hospital with previous medications. So what will continue with him? What will be changed? What will be stopped? What will be added? Maybe the same medication, the dosage will be rearranged. What is the medication name? Why does he need it? If he has allergy to some compound, are other drugs prone to give him the same allergy? when to take it, in the morning, for example, afternoon, whatever, okay? How to measure a liquid? This is a problem with pediatric patients, especially, because most of them are syrup, and company is putting a mark for where to fill the bottle. Usually the mark is inapparent, you have difficulty to see it. So if the concentration is not right, the therapeutic effect will not be right. If he gets to go to the pharmacy and get a refill or get a new drug, he could discuss with the pharmacy, what is the effect of the drug? Do I suspect any side effects, so that he will not be surprised and in panic? How long should I take it? 1 week, 2 weeks, 3 weeks? If I miss a dose, should I replace it immediately? Should I omit it and take the next day? Every drug has its own profile. Are there extra labels on the container? This is very important. Where do I store it? Don't store it in something hot, very cold, very damp. Maybe the drug will get ruined. This is a prescription label. These auxiliary prescriptions are very helpful. Auxiliary label. For example, with certain antibiotic, the birth control pills will not work. Swallow the tablet as a whole. Don't crush it. Do not drink milk and dairy products with this medication, like the tetracycline. Should be taken with plenty of water. May cause drowsiness. This is very important. If he is working on a machinery or driving, he's a driver. If you give him antihistaminic, he's apt to make accidents. So he should not be driving during this period where he is drowsy. And so on. You will find other things, grapefruit, because it is famous for the acids. Take with food if it is irritant for the stomach, or take on an empty stomach, like the proton pump inhibitors. If you take them with food, their effect will not be that much. Extra tips: try to use the same pharmacy for the patient. If the pharmacist knows you, this would be better. Ask them till you feel you understand everything. Sometimes when there is, for example, he's asking for a 50 milligram tablet and I give him 100. It is not safe to crush or cut all the tablets. Some tablets it is safe, some tablets no. Take with water, not juice, especially for children. Sometimes the mother, she wants to give the medication. The child is not cooperative. She's just putting it in juice. This juice may be as acidic or alkaline or whatever. It will inactivate the drug. If there is a weird dose, like he's finding that he will take 3 tablets 2 times a day, why not choosing a bigger dose? Maybe something is wrong. Do not give the medications to your friends. Oh, you have hypertension? Oh, take my medication, it's good for me. Contact information is very important. Like, for example, if we are going through the file and then we find that something is wrong with the prescription, we should contact the patient and get him back and correct what went wrong. Also, if some medication is about to expire, better to get rid of it, get a new one. Non-prescription medication, especially herbal, can do interactions with the drugs and they are not useful all the time. So if the patient is taking herbal or over-the-counter medication, better to inquire about it. Storage, this is in the pharmacy. In some hospitals, we have the Omnicell. Omnicell, it's like a safe. It will not open for you. It will not give you the medication instantly. You have to enter in the system, then it will go to the pharmacy, then he will approve. Then the Omnicell, like a huge safe, it will open, and then it will give you the drug. This is for extra caution. We beware of heat or cold or moisture. The labeling should be right. And do not put two types of tablets in the same container. You will be confused which is which. If you are taking like insulin injection at home, have a sharp dispenser so that you don't harm somebody else. It is also advisable also for the patients to read about medication incidents and how to avoid them. If he has an incident at home, better to report it. This will increase the database. This is useful for everybody. So as a conclusion, I hope I have not been too long with you. A medication error is common and preventable. Preventable means that with our effort, it could be less and less and then disappear, hopefully. It causes human suffering, it causes costs. Medication is like everything, it is not risk-free. If we communicate the information to each other and work as a team, we will get the best of the results. And it should be our day-to-day culture. The problem is really serious. Here in the United States, it's the third leading cause of death. So to err is human, it's okay. Cover up, no, it's unforgivable. And don't be stubborn. You have to learn from your mistakes. All of us are human. And thank you very much for your time.
Thank you, Doctor, for your informative lecture. And thank you for all for your participation in this event. Any questions for Doctor before we finish this day? Anyone have any questions? Dr. Fuad?